Hello everybody, this is Dr. Rajkumar, Consultant Medical Oncologist from Velamal Specialty Hospital, Madurai. Today we are going to see few points on the health cancer awareness regarding the head and neck cancer. Head and neck cancer are one of the most painful cancers to have, and the incidence are rising alarmingly in India. The tobacco consumption is on the rise, whether it's smokeless tobacco or smoked tobacco like cigarettes, BDs, and the smokeless tobacco like gudka and pan. The incidence of the tobacco consumption and the alcohol consumption keep rising among the young population in the India. That's the reason why we are having higher incidence of head and neck cancers. Head and neck cancers are prevalent in many parts of India, including the northeastern part as well as in the southern part of India. The higher prevalence being in the northeast part of India, like the Meghalaya, Meghalaya and Nagaland and other northeast countries. And we have also a very high incidence among the southern states of Andhra, Kerala, and Tamil Nadu and Karnataka. Why? Because the incidence of the smokeless tobacco in the form of gudka and the cigarettes and BD consumptions on the rise among the younger generation of populations. Around 55% of the men do use the tobacco, and 11% of the Indian women do consume tobacco in either form of smokeless or smoked one. So the incidence of the head and neck cancer forms a very heterogeneous group of cancers arising from the different parts of the head and neck, including the lip and oral cavity. As you can see from the slide, it forms a very high incidence of 60% on the lip and oral cavity, and 9% in the oropharynx, 14.5% in the larynx, and 2.6% in the nasopharynx, and the 13.1% in the hypopharynx. So the lip and oral cavity predominates, is the highest incidence occurs because of the use of betel leaf along with the lime, as well as the combination of tobacco along with this betel leaf and lime. So the higher incidence of chewing tobaccos is the reason for the increased incidence of cancers in the lip and the oral cavity. The fire prevalence, as you can see, is very poor in the nasopharynx and hypopharynx and the laryngeal cancers when compared to the lip and the oral cavity cancers. Next slide, please. Higher incidence of nasopharyngeal cancers in certain part of northeast countries like in Nagaland, where the incidence is 9 in 100 or 1 lakh population. Next slide, please. So different geographical areas do have different incidence. As you can see from the Globacon 2020 data, out of the total cancer population of 11 lakh populations, you have the higher incidence in the lip and oral cavity predominates in the form of 10.3%. This is the recent data of Globacon 2020. Next one is the 10th leading cause of cancer in India, and one of the very morbid conditions which is associated with the head and neck cancer, because more than 80% of the populations are diagnosed in the advanced stages of involvement of the oral cavity, and only, unlike the Western population where 20% of the patients are detected in the advanced stage, in India more than 80% of the populations are detected in the advanced stage, even though it's easily accessible organ, even though the head and neck and the oral cavity easily can have a examination of the throat as well as examination of the head and neck region is very easily accessible one. The incidence of detection rate is very poor, and it is usually detected when it is a fungating mass and is advanced stage of involvement of all the bones and all. So even though the head and neck cancer, when compared to the other cancers, has got a very long pre-malignant stage where it goes through a lag period of many years, where easily that intervention can prevent from the pre-malignant condition to a malignant condition, and you can arrest the pre-malignancy progressing into malignant condition with tobacco cessation and other measures. Still, in India, 80% of the head and neck cancers, especially the oral cavity cancers, are detected only in the advanced stage of the disease. As you can see from the picture, the head and neck cancer regions is basically classified into a oropharyngeal region, a laryngeal region, hypopharyngeal region, and salivary gland tumors, and then nasopharyngeal tumors. So these has got a different prognosis, and these different regions do have different treatment schedules, and different expertise are required. The surgical expertise, the radiation, and the drugs also differs from different regions to other, and they have prognosis also differs. Out of that, the oral cavity cancers which forms a majority and is got a good prognosis when compared to the other regions of the head and neck cancer. Next slide, please. The risk factors, as we all told, the tobacco and the alcohol consumption predominates is the drivers of the cancer, and more than 8-fold increase in the incidence of cancers occurs in the consumption of tobacco and alcohol, due to more than 8 to 20% of the increased incidence of cancer. And virus also do play in, unlike in the Western populations, the role of virus is little less when compared to the Western population, but still the change in the practice of oral sex and sexual pattern is more, unlike in the Western countries, we also have a change in the sexual practice. So we leads to increased incidence of the herpes simplex virus transmission, leading to the virus being a driver in a non-alcohol or non-tobacco related cancers. So, but predominantly the 60 to 80% is the tobacco related cancers. Next one. As you can see, the tobacco consumption can be in the various form. It can be a snuffed one, it can be a hookah. The different regions of the India, being a heterogeneous populated state, they have different consumption, pattern of consumption of the tobacco, either the filtered cigarettes, non-filtered cigarettes like BDs and hookahs, are in the form of snuff using, and they are chewable tobaccos in the form of pan and gutka. So various patterns of consumptions differs from one region to another region. Next one. The chewable tobaccos are usually associated with the buccal cavity cancers, gingiva buccal sulcus, because the chewable tobaccos are kept in that region for a longer period of time, leading to the cancer of the buccal mucosa. As I told, the viruses like HPV, which is the predominant one, which is responsible for the transmission of the viruses through the oral sexual activity, they are also responsible for the drivers of the cancers in the patients who are non-consumers of alcohol and tobacco. Next one. Symptoms differ from different regions of the head and neck to the different thing. It can be presenting with a painless nodes, non-healing ulcers in the oral cavity, chronic pharyngitis like symptoms, neck nodes, which does not goes away with the antibiotic, or white patch, or more ominous red patches. The white patches are called leukoplakias, and the red patches are called the erythroplakias. And these are the pre-malignant conditions, and they have long latent period, and they can be successfully pharmacological or non-pharmacological intervention can help to reverse this thing and prevents the progression into malignancy. So next slide. As you can see, nasopharyngeal cancer or the nasal cancers can present with the bloodstained nasal discharge. The skull-based lesions can lead to double visions, unilateral headache. All the nasopharyngeal or the oral cavity cancers have a ruffled pain in the frontal region of the unilateral headache. Next one. So the symptoms are going to differ from one region to another region, individual to individual. Next slide. It can be a chronic pharyngitis which does not go away with the antibiotics, a sore throat which does not go away, ruffled pain and otalgia. Next one. Difficulty in swallowing, a dysphagia, long-lasting sore throat which doesn't go away with your antibiotic, neck nodes, neck swellings, white patches, which doesn't give little painful also. These white patches on the lips can be very painful also. Lump over the neck, which is all secondary cervical nodes. Next. Once again, the dysphagia and hoarseness, weight loss are the last one to come. These are not the earlier symptoms. Weight loss in the head and neck cancers comes later on. And the erythroplakia is a more ominous sign of malignancy. Reddish patches on the undersurface of the other sides of the tongue, and the white leukoplakia is a white one. Erythroplakia is a red one. Erythroplakia is a more higher chances of getting transformed into malignancy. There are the precancerous conditions. Still, the time lag is there. Still, they can be prevented to progression by tobacco cessation and other pharmacological and non-pharmacological measures. Next one. These are the various submucosal fibrosis are the one which is very common in Indian populations, is peculiar to the Indian population, where the chewable tobaccos can lead to a submucosal fibrosis, very thickening of the tissues around the oral cavity, which results in inappropriate opening of the oral cavity, not able to open the mouth, not able to open adequately the mouth. These are the features of the submucosal fibrosis, which is once again a pre-malignant condition, which is very peculiar for the Indian population. This is once again the white patches on the palatal surface, upper surface of the palate, and oral leukoplakia. So the symptoms and signs are, head and neck cancers are easily accessible. It can be very easily picked out by the primary care physician or even by the patient themselves. They find that there are white patches are there, red patches are there, which is not going away with a simple treatment, and it keeps coming up. And these are the things which requires immediate attention and intervention. So biopsy requires a biopsy, a tissue biopsy from that. Next one. So that basically we like to do the biopsy. This is the first thing primary care physician will do. They will do the imaging to find out the extent of the disease, and they will assess the oral cavity. The ENT surgeons will assess the oral cavity and the naso and nasopharyngeal cavities, and try to do a biopsy, obtain the tissue for the laboratory diagnosis of the cancer. It will come within a week that whether the cancer is present or not. So it requires a multidisciplinary approach. All these specialties like the ENT, dental, as well as the surgical, as well as the medical oncologist and radiation oncologist comes into play. Usually the imaging in the form of the MRI is taken to assess the extent of the disease and the staging of the disease. Next one. Hpv test, after obtaining the tissue biopsy and confirming it is a malignancy, the Hpv test or the viral presence of the virus can be assessed. The prognosis differs between HPV positive tumors from HPV negative tumors, and HPV positive tumors are one which have a good prognosis when compared to HPV negative tumors. So HPV positive tumors nowadays are on the rise. Is the decline in the Western population with the decline in the tobacco consumption, the increase in the viral driven cancers are on the rise, but India is still 60 to 80% is only tobacco related cancers. The HPV positive tumors are little higher on the metros, but in the rest of the India is a tobacco driven cancers. Next one. Either you can do a contrast CT, FDG PET or an MRI to assess the extent of the disease, to stage the disease. Next one. Is a multidisciplinary approach with the dental surgeons. The patient may land up with the ENT surgeon with the dental surgeon, who are all forms the primary care patient. Then they, after the diagnosis, they'll refer to a oncologist, either a surgical radiation or the medical oncologist for the further treatment. These are the various triple endoscopies are there, where the nasopharyngeal cavity is examined with the endoscopy, or the esophageal thing. All this is what is called the field cancerization. All the upper aerodigestive tract can involve if you are a heavy tobacco user. Staging, depending upon the extent of the disease, it is classified into stage 1, stage 2, stage 3, and stage 4. And the treatment modality differs from stage 1 to stage 2 to stage 3 and stage 4. Stage 4 is always a palliative treatment, incurable disease, requires a chemotherapy. And stage 1 and 2 and 3 requires a multimodality treatment approach. Predominantly in India, if it is operable, the tumors are operated by the surgeon. If it is inoperable and found to be locally advanced, it requires a multidisciplinary approach, either in the form of a concurrent chemo or what do you mean by concurrent chemo? Is combination of chemo plus radiotherapy. The radiotherapy is executed for 30 to 35 fractions of radiotherapy is given along with the chemotherapy in a weekly fashion. So concurrent chemo, a combination of chemo and the radiotherapy is given for a locally advanced disease. And for early stage disease, it is usually a surgery. And for locally advanced disease, combination of the chemo as well as RT, and it is the stage 4 is usually a chemotherapy. Next one. So up to stage 4A, it is a curable one, and after stage 4 is the stage 4B, it is incurable disease. But majority of the head and neck cancers are within the stage 3 or stage 4A, where it requires a multimodality treatment in the form of a concurrent chemo RT. Next one. Next slide, please. Next one. The treatment, as I told, the early stage of the disease, surgery is an option where small lesions are usually excised with or without the help of a plastic surgeon also, especially in the lip and oral cavity. Surgeries are done along with its my surgical oncologist, general surgeon does the surgery, and along with the plastic surgeon, reconstruction of the last portion can be done. And if it is, the surgeries are all done for the early stage of disease when the lesions are very small in size. If the patient has got a locally advanced or the involvement of other structures, surrounding structures nearby, then you have to go for the multimodality treatment in the form of combination of a chemo and a radiotherapy. Next one. This radiation here is usually given by an external beam radiation or by the brachytherapy, but more commonly the external beam radiation therapy is used where the telecobalt source or IMRT techniques are used, where the patient is going to a CT scanner-like machine and they are exposed to radiation, a shorter duration of radiation for a few minutes, 2 to 5 minutes, and they will be fractionated into 30 fractions, 5 days in a week, up to 1.8 to 2 grays per fraction. So the patient will be receiving radiation for 30 days to 35 days, 5 days in a week, along with the weekly chemotherapy. So this usually will take care of the locally advanced head and neck cancer. Next one. Chemotherapy is used along with radiation for the locally advanced head and neck cancer, and for the advanced one is usually a chemotherapy, a palliative chemotherapy. When the head and neck tumor goes to the lung or it involves the other organs, you go to the skull base and all, it's called as a stage 4 disease. And if it becomes stage 4, it becomes incurable and you need a chemotherapy. The chemotherapy is usually given in the intravenous fashion. Nowadays, targeted agents and newer treatment modalities are available, which can also be given in the form of oral tablets. So conventional chemotherapies are given in intravenous fashion by hospitalization. But the newer treatment modalities can be given in the form of oral tablets. And now recently we have the immunotherapies. Once again, it reactivates the dysfunctional immune system to fight against the cancer. So immunotherapies are also now is used in head and neck cancer. So we have chemotherapy, we have targeted agents, and we have immunotherapies, which are the latest one. The immunotherapy, as I told, is a checkpoint inhibitors, which is the novel way of treating cancers, where the dysfunctional immune system, the cancer cells escape from the immune system, and by giving these drugs, you reactivate our own immune system to fight against the cancer, which is more efficient and less toxic when compared to giving a chemotherapy, which kills all the cells. So this is a better way to address the cancer. Prevention, head and neck cancers is always, I told, it's got a very lead bias time is high. They got a very pre-malignant condition. it slowly progresses from a pre-malignant condition to a malignant condition. So you have ample time to stop its progression from a precancerous condition to a cancerous condition. So we have a prevention strategies are very important. Prevention strategies can be very simple psychological support for tobacco cessation to up to vaccination. We have different one. So most effective ones is the psychological counseling and the group counseling to have a tobacco cessation, alcohol cessation, and the antiviral drugs. And you have the vaccines also for HPV vaccines also there. Healthy lifestyle. It's cancers are all lifestyle diseases, so you need a healthy lifestyle to be maintained with a lot of consumption of vegetables, fruits, and a lot of avoiding all the sugary diets, fast foods, and avoiding alcohol and tobacco leads to a prevention of cancer. Next one. Prevention strategy, as I told you, is mainly tobacco cessation. In India, it's tobacco cessation and HPV. We have HPV vaccinations, and we have the healthy lifestyle has to be taken with a lot of vegetables and fruits and less consumption of sugary items and less consumption of fatty meals. Next one. Thank you so much for the patient hearing. Thank you.